Could you discuss what are the most common causes of chronic pain and related opiate issues in HIV-infected patients?
So the most common causes of chronic pain in the HIV clinic are going to be chronic injuries to the nervous system. The most common one we used to see was HIV neuropathy, and then related neuropathies that you get from, as we get an aging population, diabetes and other metabolic syndromes which damage nerves. Those kinds of pain produce a chronic, what I will call dysesthetic pain. It's a kind of, patients call it a cold burning pain. It's mostly peripheral. It usually happens the further you get from the center of the body, the worse the pain is. So we call it a stocking and glove distribution of that kind of pain. And that pain responds to lowering HIV viral load to undetectable, and then a variety of things that help your brain distinguish between what's real pain and what's kind of noise from the nervous system. So I talk to patients about hydrotherapy and getting their feet in water and using their limbs so that they can distinguish between what is and what isn't painful. And then a variety of medications are very effective for those kinds of pain, but it's trial and error in any individual patient. Tricyclic antidepressants, particularly nortriptyline, we tend to use very low doses. It's better to use doses that produce a blood level that's over 100 nanograms per deciliter. So between 100 and 150 is the target for me for nortriptyline. People who don't use enough anticonvulsants, lamotrigine, valproic acid, carbamazepine, these are all excellent chronic pain drugs that we tend to underutilize. The two favorites now are gabapentin and pregabalin, also both very useful in some patients. Some patients respond well to calcium channel blockers. That's the commonest thing people see. There are a variety of pain syndromes that are called central sensitization syndromes, which are caused by damage more centrally or by some injury that has trapped a nerve in scar tissue, chronic low back pain, other kinds of pain where people are injured. And that pain needs to be treated with mobilization, physical therapy, and similar medications work for lots of patients, but it's harder for that kind of pain to find the right cocktail of medicine. The other thing is that there's a huge comorbidity with major depression. People with depression don't gate pain very well and develop these central sensitization syndromes very easily. Complex regional pain syndrome is an example, or what we used to call causalgia, or sympathetically maintained pain syndrome. That syndrome is fairly common in the HIV clinic and is very tough to treat unless you treat the person's underlying mood disorder, which a lot of the patients have. People tend not to treat that. The drugs that really work for those patients are SNRI antidepressants, which are also useful for chronic pain of any sort. They work, for instance, for peripheral neuropathies, but they're particularly good in people with these depression-induced pain sensitization syndromes. So aggressive treatment with those medications really makes a difference in outcome. And practitioners who are inexpert in using those things can get kind of help from people who are chronic pain people and learn how to use them. They're not that hard to learn to use, but they do require practice and some kind of teaching experience so that people can show you how to try things and how to use them and what doses to use.